The following is a conversation with Professor Anthony Hobson, the founder and CEO of the Functional Gut Clinic. The Functional Gut Clinic is the UK's leading gut health diagnostics, testing and services business. Anthony and I have been friends for many years. We're now collaborating on a phase 2 randomised double-blind placebo-controlled trial investigating the use of full-spectrum microbiome therapies in patients with IBS-C and IBS-D. And it really was just such a pleasure to have him on the podcast today. He is super knowledgeable, both in terms of how to start and build a business in this space, and learning from the journey that he's been on over the last 10 years with functional gut, but also as a scientific expert and a gut health and microbiome expert. So what we learned about today, what we discussed, was all about the current state of microbiome diagnostic testing, gut health testing. What is functional testing of the gut? And one of the key lessons and take-homes is that to truly understand gut health and to work towards gut health, you have to understand how the gut functions, and different aspects of the intestinal tract have different functions and respond better to different tests and treatments. We talked about the journey that he's been on building functional gut and how the field has evolved. We spoke about TummyMOT, which is an initiative that he and his colleagues have co-founded, really focused on bringing zero-cost information to patients and consumers about which supplements, be they probiotics, prebiotics, foodstuffs, actually work, what is supported by good evidence. They also do a lot of very good information on social media, which I highly recommend you check out. Hopefully we can get Anthony back on again, because we actually run out of time today, even though we were going for over an hour and 15 minutes, as happens sometimes in Inside Matters. Now, none of this would be possible without you, the listeners, and your engagement and your support. If I could very kindly ask you to hover your finger over the 5-star rating button and give us 5 stars and a positive review, because those are the best ways to support the podcast. If you've got any questions or would like to see a topic addressed, please reach out on socials or at james@insidematters.health. This is Inside Matters. My name is Dr. James McIlroy. I hope you enjoy it. So why don't we just start with a kind of big question then, which is, what does gut health mean for you? What is gut health?
So, the gut is basically your interface between yourself and the outside world. It's the biggest surface area between you and the outside world. So therefore you'd think you'd look after it a bit better, because most of the challenges that you'll have to your health will first start from the gut. And yet it's so far down the list of considerations for both people and clinicians. Our mission for Functional Gut has always been to say to people, what are you doing? This is really important that you look after your gut. You have to understand how it works, how it functions. And once you understand how it functions, then you can, it's like a car engine. You can put in the right fuel. You can make sure you service it regularly. You make sure that you give it a rest when it needs a rest. And you can protect it when it's at risk. So, gut health has to become front and center of our approaches to medicine. And if you consider what gastroenterologists do at the moment, many of the treatments that are first line are actually deleterious to certainly the microbiome and to gut function. So I think there's a lot of learning to be done.
If you could take us back to the kind of very start. And these days, gut health is something that people talk about. I've noticed a huge change in just the last 3 years. And we'll get on to which information is good and what's not so good later on in the conversation. But what was it like back when you started in terms of the appreciation of the importance of the gut?
So I think most people who have gut symptoms, when they encounter the primary medical system or whatever, the doctors, what they're concerned about is, do you have cancer? And when you don't have something serious like cancer or inflammatory bowel disease, they go, whew, well, good luck, go and live with your symptoms.
Yeah.
So the gap between your quality of life in sort of primary care, subclinical, maybe just over primary care, and then ended up in tertiary care is huge. So you're either very, very serious or you're going to go on and live with it. And I think when we started Functional Gut, it was really to try and bridge that gap. So we started off in secondary, tertiary care for those people who might need an operation, say for gastroesophageal reflux or pelvic floor dysfunction. And slowly we've kind of elongated back down towards that primary care, and actually to people who aren't patients, who just want a better version of themselves, whether that's in sports performance, whether it's just preventing illness, not getting as many colds and things like that. So, I think education is key. And unfortunately, the medical education for gut health is quite poor. So they concentrate on things like endoscopy, inflammatory bowel disease, liver disease, the big ticket items, which understandably are important. But that's about 40% of the patients with gut symptoms. The 60% of people will have what they call functional problems. And what functional means is we don't know what's wrong with it. And we always use the kind of analogy is, you're in a car showroom, you see a beautiful car, you're going to buy it, but you're not going to buy it without doing a test drive. And when you test drive it, it drives like a dog. That's how the car functions. Yeah. So just saying, you're not going to say it's a functional car. You're basically going to say, well, this needs sorting out.
Does it function well?
Yeah, so you put the camera down, everything looks shiny and new, but it doesn't mean it's functioning properly. And that's the gap that we're trying to build here, is saying, okay, so you've ruled out something nasty and sinister or whatever. But really, the important thing is, how can you make this sort of engine of, if you think about it, all energy that comes into your body comes through your gut. Without your gut bringing that energy into all the other organs, nothing else works. So why would you not make it front and center of everything? So, that's where we're trying to bridge that gap for education.
Many of the people listening will have had that conversation with a doctor where the doctor has said, well, you've just got IBS. That's it. You've just got IBS now. Away you go. Nothing we can do. Maybe change your diet. Peppermint.
Can I just tell you a little story?
Yeah, please. Yeah.
So about 10 years ago, I got some money from a drug company to do an IBS awareness day. So it was great. We did it at the Queen Elizabeth Centre in London. And I thought I'd take people through the journey: primary care, secondary care, tertiary care, dietitian, patient perspective and everything. And I got a gastroenterologist to do the secondary care journey bit. And he stood there, and this is like 150 people in a conference room. Half of them are patients with IBS. And he started off his talk by saying, that heart sink moment when an IBS patient comes through your clinic door? I
think that's how they feel.
Everyone just spat their water out. It's like, I'm just thinking, what on earth are you doing? He's going to get lynched. But that's kind of what a lot of them think,
100%.
So it's sad. It is the commonest thing they'll see coming through their door. But they often don't have the tools to, deal with it. And that's what we're trying to do. We're trying to educate them and go against this current of, I guess, antipathy, really, of it's not serious, go and live with it. It's a lifelong condition. It's not a lifelong condition. You can sort it out.
Absolutely. Well, when I was at medical school, I remember very clearly the GI stuff because I was most interested in it. Everything that we were taught, be it in textbook, lecture, video, whatever, was IBS does not have an impact on mortality. It is a diagnosis of exclusion. Right?
Yeah.
So essentially you rule out everything else and you've got IBS and you tell the patient to basically go away.
Yeah.
Nothing we can do for you. Even worse, it's all in your head. It's a disorder of the gut-brain interaction. Right?
Yeah.
We think we now know that it's just not all in your head, right? And I want to get into the science and all the work you're doing. But just to kind of go back to the start of Functional Gut Clinic and this diagnosis of exclusion piece. Did you have a vision in your mind that over the years and decades, you would start to change that diagnosis of exclusion to, oh no, we can tell you why you're having these symptoms based on biological parameters?
I think back then it was quite a new science of phenotyping. And the reason that our company logo is a brain and a gut is because the two are interacting all the time. So there's no doubt my PhD was on brain imaging. We mapped out the sensory representation of the gut onto the cortex to show there was a visceral homunculus. And then we were involved in brain imaging studies where we would take healthy subjects and make them more sensitive, either by sensitizing their gut with acid, which is quite cool, or capsaicin, chili. Or we would show them things like scary faces or play sad music. I think it was Under the Mongolian Yoke or something, some Russian music. You play that to them, you make their rectum more sensitive.
Really?
So, yeah. So, but basically what you're showing is that the brain and the gut are intimately connected. And for some people, it's predominantly brain, because you've basically got filters within the brain at various levels that allow more visceral traffic to come through or shut it down.
Yeah.
So your idea is to, when you do things like diaphragmatic breathing or stress relief, you're having descending inhibition of visceral sensations. But when you're stressed, as you know, you feel your heartbeat going, you get
the butterflies
in your stomach.
Yeah.
They're probably happening all the time, but you're only aware of them when your brain wants you to.
Oh, wow.
So if that becomes a permanent state, then obviously you want to kind of turn the filter off from the top end. What we did with IBS is we gave electrical stimulations of the rectum and showed that in basically a symptomatically homogeneous population, you had a massive spectrum of sensitivity. And if you stimulate the nerves, then the nerve impulse goes up to the brain. You can measure the size of that. And some people would report it as painful, but the signal around the brain is tiny. And some people, where the sensitization is in the gut itself, then the signal coming up from the spinal cord is massively amplified.
Interesting.
Two completely different mechanisms. This person needs, we used, I think, ketamine at the time as a way to get rid of sensitization, just as a rough tool. But the idea was that drug companies, so it blocks the peripheral sensitization and central sensitization
in IBS patients.
In IBS and other things like non-cardiac chest pain. Whereas a lot of other drug companies were looking at things like CRF antagonists to try and switch the brain off a little bit. But the problem is the gut only has a few nerves compared to, say, like the finger or what's going on the spinal cord.
The vagus.
But the vagus doesn't promote pain. So all the painful signals go through the spinal cord. So what happens is if the gut is alarmed,
that's interesting,
it starts to borrow nerves from other regions, and that's where you get referred pain. So if you get a pain in your esophagus, you probably feel a little bit of something, but then it gets worse, it spreads across your chest and down into your arms. Same with abdominal pain. So it kind of borrows nerves from other regions to tell you something's wrong and then change your behavior. But if you try and drug that with a medicine, the actual number of nerves in the gut is so small compared to what's in the rest of the body, then you kind of run the risk of having lots of side effects. So peripheral sensitization drugs didn't really go very far. And I think what people have now started to work on is how can you boost the endogenous pain systems. So whether this is things like gut focus yoga or diaphragmatic breathing or vagal stimulation to try and, switch those signals off, they seem to be more effective because you're never really going to get a gut-specific analgesic, I don't think.
No. How powerful are these breathing techniques and the yoga and the vagal stimulation like that you see in your clinical practice?
I think they're, if you're motivated and committed to it, I think they can be incredibly powerful.
I feel the same.
We always do things slightly differently. So the model that we had for chest pain was we put acid into your esophagus, and then that would sensitize the nerves and you would get more nerve impulses. And one of my colleagues, Adam Farmer, then put a little clip on the ear to do vagal stimulation and showed that if you do vagal stimulation while you put acid in there, you don't get the sensitization. So the powerful
it's a real thing,
inhibitory effect of the vagus blocked that spinal sensitization. And then he gave atropine to block the vagal response, and sensitization came back.
Wow.
So as an experimental medicine study, it was perfect.
It's nice.
And that's why we're now trying with some of these patients who have intractable symptoms, vagal stimulation, but also diaphragmatic breathing and gut focus yoga and things to
I love that.
Just see if they can, because what you're trying to do, there's basically a kind of filter in the thalamus that allows traffic to come through, and what you're trying to do is just turn that down. And of course hypnotherapy was used quite extensively by Peter Warwell in IBS. And did
it get traction?
It did in Manchester, and there are still hypnotherapists who do it. And I remember doing it with in Manchester, and I'm sat there as a kind of young researcher thinking, God, this is crazy. Peter's there, he's got this big, deep, booming voice. He's got a dicky bow on that looks like it's going to spin round at any moment. And he's like, you can hear a distant bell and you can see this. And I'm thinking, what a load of... Next minute, this volunteer who's doing it is like, boom, gone. And I start stimulating the esophagus, and her pain thresholds go right up, the brain signals go right down, and it was just like,
It
okay,
worked.
I'm converted.
It worked.
Yeah. The brain's a powerful thing.
Oh my goodness, yeah.
And then suddenly he clicks his fingers and she wakes up and she's like, wow, I feel euphoric. I feel fantastic. This is great. And I'm just like, right, so maybe I need to start reassessing my opinion about things.
That's awesome.
That's the great thing about science, isn't it? That you go into it with an open mind-ish. You have your own opinions. But you've always got to look at the data as it comes through. And when the data is impressive, you're like, wow, we need to develop the model. So we have models of sensitization. We have models of top-down inhibition. We have we know how it all works. It's just a question of how you bring that all together to help people and patients.
Although I think for some things like meditation, breathing, hypnotherapy, more sort of Eastern philosophy approaches, you would find that it would be quite difficult to get a big audience in the Western world. Because here it's all about, molecules, receptors, drugs.
Yeah, and I think there is a bit of backlash against that. There is an amazing book called The Science of Breath, which I'll give you a copy of.
Yeah.
And it was written about 100 or so years ago by one of these yogi philosophers. But it talks about the solar plexus and the second brain and all this stuff that we now think is new.
Yeah.
But these guys were doing it hundreds, if not thousands of years ago.
I would like to read that.
But you have to be careful, because if you go to the very, very complex breath techniques, then you start to see the future and it gets a bit scary.
To be honest with you, I'm fully bought into all of this. Yeah. I'm not a skeptic at all. I was. Like, when I was at medical school, I was like, no, if there's not a Cochrane review, multiple randomized controlled clinical trials, I'm not interested. Yogi, breathing, woo-woo. Cold water therapy, woo. Now I've gone complete 360. I'm a huge believer and a huge proponent of the diaphragmatic breathing, for example.
But it's not exclusive.
It's synergistic.
Yeah,
it's synergistic. So, that's the thing.
So you can believe in these things, but you can also generate some evidence for them as well.
Yeah.
And that's what we did with the vagal stimulation. We think it works like this, so we gave atropine and it blocked it, and it does work like that. So you've got a mechanism. So I kind of sit in between that. Placebo is very powerful.
Oh my goodness, yeah.
Nocebo is powerful. We've had talks on that in the past, how people think
for the listeners,
very bad for them.
Could you tell me a little bit more about the nocebo?
So that's when you presume something is going to give you symptoms. So it's going to have a negative effect, and then you develop a negative effect even though it is a placebo.
Right. That's pretty interesting, isn't it? Yeah.
And I remember going back 10 or 15 years, we did a presentation that, is it right to give, if the placebo response rate in IBS is 50%.
Why don't you just give a placebo?
Yeah.
Yeah.
And I was kind of against it because I was still in my kind of righteous scientific mode of, no, we must do it properly.
But it feels, why not?
Yeah. It's like magic pill.
Yeah.
But it does feel a little deceitful. So, yeah, I think with a lot of these techniques, it's not, and this is what we do quite well at Functional Gut, is that if there's a question out there, we have the capability of checking it. So I don't know if you saw recently Jordan with a tube down him doing the baking soda low stomach acid test. So much rubbish out there about this, right. If you think this is what works, then we're going to show you why it doesn't work. Yeah. And in some people who do have achlorhydria, so low stomach acid, it's nasty. It's a proper condition, and you can treat it by taking some supplements, hydrochloric acid supplements and things. But you don't want to be spending money on those things if you don't have low stomach acid. If you don't need it,
right?
Yeah. So baking soda, you don't burp for 5 minutes. Low stomach acid. Jordan, bless him, with his tube down, proving the point. And that's what we're doing the same with gut permeability. We've done it with hydrogen sulfide, and it's kind of, I guess, this boost in gut health and the interest in gut health from lots of practitioners and people has slowly wound us in from secondary and tertiary care further down that pipeline to say, look, we're highly regulated up here.
Oh, yeah.
But you guys aren't. So you're saying all this stuff, and we probably need to raise standards, and we want to do it in a collegial way. If you've got a product or you've got a test or you've got an idea, then let's work together to see if it works or not. If it doesn't work, you move on to the next thing. So we're not kind of, trying to clickbait and be controversial. We're just saying the evidence is that this works, but there's no evidence of that. It doesn't mean it doesn't yet, but why don't we all work together to make it happen?
Agreed.
So it's just raising standards and debunking some of the myths.
Mm-hmm. What are all the kind of full repertoire of things you're now offering at Functional Gut, and how has that evolved since you started the business?
So I think, as I said at the start, when we started off with some of the more kind of invasive stuff, so putting tubes down or up people to look at gut function, see whether they need surgery. And then in 2017, we did a joint venture with Commonwealth Diagnostics in America, who have pioneered a kind of home breath testing kit for things like small intestinal bacterial overgrowth and carbohydrate malabsorption.
Just one question. When did Functional Gut Clinic start?
It was 2014.
2014.
2013, 2014.
Congratulations on 10 years of business.
Yes.
Hey, that's really good.
Yeah. And
10 happy years?
10 happy years. Yeah, I love it. You know, it's every day I wake up and feel lucky, both with the people that I work with, for the patients that we see, and for the area that we're in. You know, I still find it fascinating, and that's why I could probably do this podcast for about 5 hours today.
Yeah, me too. But we won't go for 5 hours. One day I'll do some mega sessions, but what I found is that most of the audience is actually deeply interested and quite technically literate and astute. But there is a growing following of people who are patients, or family members of patients, who don't want 5 hours of like the complete deep dives on hydrogen sulfide production, for example. So I'm trying to create a blend of content. What you guys are doing at TummyMOT and through Jordan, I think, is excellent, because that's, well, excuse the pun, very digestible. It's short, it's crisp. You get exactly what you need to know really quickly. Whereas I'm trying to position the podcast more around, we get experts like you on, and we do, an hour and a half, whatever. But we're trying to pad that out with a kind of 10 to 15 minutes shorter biome bite type episodes.
Yeah.
And we have had a couple of 2 or 3 hour marathons, but they're not as popular as other episodes. So we're just trying to create a blend of everything. What I'm trying to say is we'll talk a lot about interesting things today, but not for 5 hours.
Yeah.
But we still want to hear. We still want to hear your passion.
That's fine. And with the TummyMOT content, deliberately at the start when we started it out, I basically said that anything that I like or approve of, don't use, because my generation, I want to be scientific. I want to be like, so if I think it's a good idea and it's looking good, they're like, actually, Anthony, we don't want to watch a 37-minute YouTube video. We just want to know how to get some cheap kefir from Aldi.
Yeah. Well, talk about TummyMOT then. So what is TummyMOT? How does it relate to functional gut?
So we talked about it for a while, and again, it was more around, because we're seeing like 7,000 or 8,000 IBS type patients a year. Then we get lots of questions from them. Should I be taking antibiotics? Should I be taking probiotics, prebiotics, whatever? And you go in Holland and Barrett and all these other shops, and you just huge swathes of stuff that nobody knows. So it was really taking a bit of Martin Lewis inspiration of, can we do the same thing for the gut?
Yeah.
And we've got to be careful. We don't want to be ultra critical, but we, went out and looked at a load of products and said, right, okay, these products, they've done great clinical trials, they've got evidence, they've got the label, they're tummy trusted. So, they've done it. But then some other products here, they've said they've done 300 clinical trials, but the clinical trials were on zinc and vitamin C, which are additives, not the strains or the probiotics that you want. So actually, there's no evidence to support that strain or species has any effect in that dose. And we did, go out, reach out to the companies. So we say, look, have we missed anything? Are we being fair? And, they say, well, sometimes they respond, sometimes they don't, and we do it. But ultimately, the truth is there. Yeah. That's what they've done.
One of the companies that I have not clashed with, but there's a company called Heights, and I'm happy to say, because I'm not a competitor of theirs, or this is all available on LinkedIn, but someone related to the company Heights, who I wouldn't name, posted something to say we've had 300 plus or something along these lines, might be wrong, clinical trials for our formulation. And I thought, 300? I've never heard of so many clinical trials being done for anything before, unless it's like, paracetamol, aspirin, something like
PPIs,
that. PPIs, something super established. I've never heard of So I actually checked myself on PubMed, clinicaltrials.gov, all the publicly available registers. I couldn't find a single study. Not even one.
No.
So I thought, so I actually commented and I said, look, I haven't seen a single clinical study of your product. I think what you're saying is the constituents of my product, species level, have been studied in hundreds of different clinical studies. And I said, but that's not your product.
No.
You have created a combination, proprietary combination, and you're selling your proprietary combination as though it's had 300 clinical studies. That is, at best, misleading. And I think that I think it shouldn't be allowed.
Yeah, and we kind of had the same review of that product as well. And, you know, if you look at some of the, like say, I think it has like zinc and vitamin C or something like that in it.
Yeah.
So there's lots of trials on that, but not specifically to that. At the BSG this year, the British Society of Gastroenterology, Malvina Naibi gave a great talk, a microbiome masterclass, talking about the difference between species and strains. And she used it as kind of like, you know, hard cheese, cheddar cheese, cathedral city. You know, it's really good context to put in there.
That. Is that available to see? Is it online?
It was on demand, yeah. So I don't know if it's still available, but yeah, she did a really, really great talk. She works for ADM Protexim, and I think the message there was that there are companies out there, companies like Simprove and Alpharex and a few others who've actually gone to the trouble and the expense of doing proper clinical trials.
Yep.
And therefore their claims are based on real
Evidence.
data.
Yeah.
But, you know, what seems to happen now, if you think about the gut supplement and food supplement space now, is it worth something like $36 billion in America?
Enormous.
It's growing at like 10 or 12%.
It's an enormous market.
So if you get a load of influencers, if you think about who we were promoting Heights at the time, then you get traction, people buy it, and even if you get a small bubble of activity, that's probably quite income generating. And you know, the Kardashian supplement that we're supposed to promote, let's call it female health.
Yeah, yeah, right.
You know, it was sold out in like 10 minutes, even though there was no evidence for it. So, you know, this is what TummyMOT is about. And what we're trying to do is build up a portfolio of trusted products that people can then try themselves. And if people then want to, you know, design studies to test different products, then, you know, we can do that with them. But ultimately, if you're going to spend your hard-earned money, then it's still probably best to not take supplements and try and, you know, do it through food. And that's what we try and promote through, you know, the dietary things. But actually things like protection, resilience, building up, you know, remission from symptoms probably does sometimes require some extra help through prebiotics, probiotics, and I'm a particular fan of the intestinal adsorbents.
I know, we'll definitely talk about that. So what are the kind of fundamental basics to get and maintain good gut health? So maybe we start with kind of diet and lifestyle, then we can move to testing and supplements and so on. But what are the kind of fundamental elements that you recommend for people?
The first fundamental element is understanding how the gut works. You know, it's evolved over billions of years, and you've got tubes and valves and acid and enzymes, and it's all there for a reason. So keeping that intact, keeping that function intact is quite important. So, you know, if you take proton pump inhibitors, so antacids, powerful antacids, when they were designed 30 or so years ago, they were like miracle drugs because the treatment for stomach ulcers was a vagotomy. So they cut the vagus nerve, which then caused all sorts of other problems. So brilliant, you know, medicine, but they were only supposed to be taken for 6 to 12 weeks, get rid of the esophagitis, get rid of the ulcers, get rid of your Helicobacter, and then go come back off them. But they quickly became lifestyle drugs. So when we first did some of the trials on this 30 years ago, I remember this old guy from the Navy. We say, how much alcohol do you drink? He says, I have 1 drink a night. And I said, and how big's that drink? He's like, well, it's like half a pint of whiskey. So he comes back in.
Big drink.
Big drink. Yeah. He was only one, but he was a big one.
Drink, yeah.
And he came back in after 8 weeks on I think it was a omeprazole. And he was a Navy chef, and he brought in these curries that he'd made for us as a thank you. And he said, this is so amazing. It's changed my life. I can drink what I want. I can smoke what I want. I'm back on the spicy food. And it's just that.
Back on the curry.
And I was probably on a pint of whiskey now instead of that.
My goodness.
And
that is really amazing.
And it was at that point that you realised what you've created is not only something that cures ulcers, but it's a lifestyle drug. And that's what it became. So there are people now who have been taking proton pump inhibitors for 20 or 30 years. And stomach acid is incredibly important in maintaining, you know, a healthy microbiome. You know, whether it's gut infections, and I don't know if you saw there's a recent review article looking at a whole host of different diseases where the translocation of the oral microbiome into the gut seems to be triggering, you know, a host of different diseases. And that's mainly because, you know, I say to patients, it's a bit like when you walk through the disinfectant at the swimming baths, that's what you're doing. Your feet are going through the disinfectant. That's what all of your stuff is going through before it then gets into your bowel.
Absolutely.
And then once you've got through the stomach, people snack all the time.
Just one point on that, if you don't mind.
Yeah.
The oral microbes finding their way into the sort of downward aspects of the intestinal tract. One of the key themes that I had observed over the last, pretty much 10 years now, in different disease areas, and it's only someone who's really microbiome obsessed that would actually pick up on IBD, cirrhosis, inflammatory bowel disease, we've talked about that, but CNS conditions.
Yeah.
One of the recurring themes was, and is, Streptococcus, for example, oral dwelling microorganism. We see that quite a lot. There's another sort of, gingivalis, and they're always associated with pro-inflammatory type profiles and sort of autoimmune type profiles. And one of the explanations may well be the use of proton pump inhibitors. Because that barrier that you're talking about, that protects what's in your mouth from finding its way into the, small intestine and the has been depleted. So maybe the cure, not the cure, but maybe one of the key preventative mechanisms for cirrhosis, inflammatory bowel disease, we're going to get onto leaky gut, which is another potential mechanism, is to just stop them.
Yeah.
And one other point on that, there was a Nature review a couple of years ago, I think, that looked at a whole range of factors that have a disruptive impact on the microbiome. Types of diet, antibiotics, PPIs was one of them, alcohol, smoking, exercise, maybe even pets. And one of the top scoring ones was PPI. It's that impactful. It was on the same order of magnitude or greater than antibiotics.
Yeah.
People know that taking antibiotics unnecessarily has a damaging effect on your microbiota. That's well understood now. Mm-hmm. But how many people know about the PPIs? I think probably a lot less, right?
Yeah. And we're about to start a study with a company that makes alginates. So, I won't name the brand, but the study really is to see whether using alginates properly with lifestyle and dietary changes can be as effective as PPIs in a group of patients that have reflux. So basically, can you intervene early on in the primary care process with reflux and stop those people becoming patients further down the line and developing it?
What's the alginate? What is that?
Gaviscon.
Right.
I've said it now. Sorry.
Whoops.
But we're about to start promoting that trial, and it's a trial that was conceived by a gastroenterology colleague, Phil Woodland, and we think it's really important to say, actually, even though the nice guidelines are go straight into a PPI, why not try something different first? And interestingly, the alginates actually contain a kind of like seaweed fibre as well that has some kind of prebiotic effect.
Oh,
so we're going to be,
that's interesting.
Yeah. So we're going to be looking at
back again.
Yeah, we're going to be looking at microbiome effects, because if you can also show that not only can you control the reflux events, you can do your dietary and lifestyle things, so you prevent those people from becoming patients, but actually you prevent some of the deleterious effects on the microbiome as well that PPIs might have. You've got a dream scenario, really.
That's awesome. Well, all the very best with that. Now, I think we got here because we were talking about functional aspects of the gut and the kind of range of tools and techniques that you have at Functional Gut Clinic. Although we've definitely gone off on a bit of a tangent.
Yeah, well, I think we covered the stomach, didn't we? So we know the stomach's really important. So that was the first point.
The stomach is important.
But then the small bowel is incredibly important because it's the biggest surface area that's open up to your environment. And I always think, I think Mark Pimentel talks about it as being a bit like your dinner plate. And once all the food has been absorbed from your dinner plate, then the small bowel needs to clean itself. And I think one of the important things about you doing, not prescribed intermittent fasting, but leaving big gaps between meals and having some fasting, is the gut is very good at looking after itself if you give it time. If you're constantly snacking, then it never gets into its fasted rhythm. So when it's fasted, it goes into this beautiful rhythm, a migrating motor complex. So it starts off in the stomach and it clears all the dead cells out and all the mucus and all the bacteria and all the things that come out, and your dinner plate is clean, ready for the next meal. And I think that would be, a top tip for anyone listening is give your gut time to look after itself. Don't constantly be abusing it with, eating and snacking all the time. Occasionally, maybe go, whole day or 12 hours or whatever. Just give it a chance to
give it a rest.
Give it a rest and allow it to heal itself.
These migrating motor complexes, like what are they? What's happening in the gut when these things happen?
Well, if you think about, let's talk about owls.
Owls?
Owls.
The bird?
Yeah. So
Okay.
so say you're an owl, right? You eat a mouse. Gulp, gulp, gulp. Right? Your stomach digests all of that fur and protein and whatever, but then what you're left with is a bony pellet. So so you can't really digest that. So what you're going to do is going to just get stuck there. So the stomach, when you finish that meal, then the pylorus relaxes, the antrum contracts, and it pushes through all that waste material that you can't digest. So it's there to help you get rid of things that wouldn't be, because if you think what normally happens when a meal goes into your stomach, as you kind of digest it, it squeezes, the valves close, and it grinds it all up. But then if you've got stuff left, then you need the migrating motor complex to then clear it out. But it also clears, and this happens in the absence of extrinsic innovation as well. So it's the gut cleaning itself. So even if
it's just automatic.
Yeah. So the second brain is looking after that for you. So, your gut epithelium, I think, regenerates every 3 days, and you've got all sorts of other things going on. And, that's why you just need to give your gut a bit of time to go through its kind of rinse cycle on the dishwasher, if you like.
So what do you recommend then in terms of spacing out meals and how often to eat?
I think, there's no one size fits all, but I think giving yourself 12 hours, every twice a week or something where you're not eating, whether that's just having an early evening meal, and then because most people will have a migrating motor complex just before they wake up. That's why most people go to the toilet in the morning. When we used to do smart pill studies, you'd see that when you're asleep, the bowel's asleep, so the pill's in the colon, and like no activity in the colon.
There's no migrating motor complex when you're asleep?
No. In deep sleep. But then just before you wake up, then you start to get some activity picking up, and then it goes to like a crescendo.
Yep.
And then that's when most people would expel the smart pill.
Just to kind of round that off, does coffee have any additional stimulus to kind of just get things going in the morning?
Absolutely.
Right.
Yeah.
So
we say this to our constipation patients, a nice glass of warm water and a coffee, and, just give nature a helping hand.
Yeah. That's fascinating. Why does it... Actually, I'm answering my own question as I ask. I was going to say, why does it go to sleep when we sleep, but it means you're not waking up to go to the loo in the middle of the night?
Yeah. And that's one of the alarm symptoms, that if you're woken up by your symptoms in the night, something's not quite right.
That's a problem. Can we talk about leaky gut?
Yeah, sure.
Because we're on the small bowel. We talked about the epithelium, so that one cell layer thick lining which protects the kind of rest of your body from what's going down your digestive tract. What is leaky gut and how does it occur?
So I've always been a little bit skeptical about leaky gut. Not that it doesn't exist, but that it's as common as people think. Because if you think about, in between those epithelial cells, you've got dendritic cells, and they have little filaments that go into the lumen of the gut, like little taste buds that are constantly tasting, the lumen, looking for pathogens, looking for irritants, and trying to, preset the immune system.
Love that.
So for me, that was like the first layer of defense. But certainly now there have been some studies where you can find patients who do have an epithelium that allows more molecules to get deeper into the system. You can imagine it's quite hard to penetrate deep into the gut because there's so many levels of protection. This is why things like Crohn's disease and ulcerative colitis are so serious, because things are getting further and further into the system. But there was a nice study by a French group a while ago in IBS patients that showed that a proportion of IBS patients with diarrhea had a more permeable small bowel. And by giving glutamine supplements, that helped to repair the barrier and improve symptoms in those patients. So it was a proper study. The effect wasn't massive, but it gave you the confidence that it's there. But there aren't really good assays of gut permeability. So we've been working for about a year now or so, because there aren't any providers really in the UK for gut permeability testing. So you can do things like give different sugars like lactulose and mannitol, and then look at the proportion of those that come out in the urine. And there are other blood-based biomarkers of leaky gut now. That and there's a really nice review article by Michael Camilleri looking at these different biomarkers. So I think it is now being taken a bit more seriously. And
what's the best one, if there is one? Every assay and technique has some strength and limitation, I guess, right? So
I don't think the comparison has been done to say which is the best one, the sensitivity and specificity yet, because no one's got all of the panel of tests. So what we're doing at the moment is, as part of a research project, we're looking at about 4 or 5 of these different markers to see which ones are the most robust and which ones, give us the... It's a balance, isn't it, with a test? Because if you've got to collect urine for 6 hours, that's a bit of a pain. Whereas if you can just take a blood assay and measure it, then that's probably preferable, and then you can get towards capillary testing and things like that. So the jury's out, but I think the important thing is there are actionable treatments now. So you've got glutamine, you've got another couple of products. One is like a fiber, one is like a pea protein that seem to be efficacious in improving gut permeability. And I think that's where we start to get interested, is that we don't want to do tests that mean nothing. And this is why we've never really got into microbiome testing, because there's nothing more frustrating when someone brings a 45-page printout of their microbiome and said, can you sort that out for me? But actually, even in microbiome testing now, we're getting to the point where there are actionable things that you can do. And I think that's how we move things forward. So that's where we are with leaky gut. We're going to have a test probably launched by the end of the year, which will probably be the lactulose mannitol urine test to start off with, because that's
least invasive.
Yeah, and also probably best validated and things in sports, used in sport quite often as well in performance. And then we'll, start to do follow-up studies with treatments and build it up from there.
If someone has leaky gut, like what kind of symptoms might they have? How does it present?
So it's mainly kind of like either nerve or immune activation. So what they're saying is that these irritant compounds that normally don't get anywhere near the nerves or the immune system are penetrating a bit deeper, and therefore the gut is becoming either sensitized to that, so you'll become hypersensitive to normal stimuli, or your immune system will kick off, and you may end up, there's a link between what happens in the gut and skin conditions like rosacea and other things as well.
Massively.
So it's kind of non-specific, and then you've got the other more kind of vacuous things like brain fog and tiredness and lethargy. The really interesting thing about the gut is it's like having a small child inside you that can't really tell you what's wrong. So it sends signals to you to change your behavior. There's a brilliant study in mice done years ago about if a mouse is given some infected food, then before the immune activation kicks off and it gives it its gastroenteritis or whatever, it signals up to the brain to change its behavior. So it becomes more cautious, it goes back to its burrow, it becomes more anxious.
Really?
Because the brain is being told by the dendritic cells or whatever,
there's a problem here.
There's a problem coming. Get back to your burrow, because if it hits you when you're out in the wild, then someone's going to come and eat you.
Wow.
So you've got this early warning system. So that early warning system, if it goes wrong, then you're suddenly feeling lethargic, or you're feeling tired, or you're feeling anxious. It's probably your gut going, the naughty child inside you going, do you know what, guys? Something bad's coming.
Get to safety.
Yeah. So it's an amazing system that's evolved.
And how might sort of this leaky gut develop then? And what are the drivers for leaky gut?
So there are obvious ones. So things like, taking ibuprofen, having too much alcohol.
Half pint of whiskey.
Yeah. Things like that. So, I think those kinds of lifestyle things are probably the commonest cause of it. But there may well be other underlying causes, whether it's, like a bacterial overgrowth or, poor motility. So things are sticking around longer than they should do and causing irritation to the bowel. But yeah, the underlying causes are not totally known.
If you don't mind, we'll just touch on alcohol for a second. What do you recommend for your patients? Like total abstinence or glass of red? Drink
Absolutely
a wee bit?
Not. You talked about Jordan and TummyMOT. Then, as part of the Mediterranean diet, then it was a large glass of red wine every night.
That's quite nice. I mean, I could subscribe to that for sure if that was the way to go. I mean, goodness sake, And a lot of people said no amount of alcohol is safe, and
I think you've got to put it in the context that alcohol in moderation is fine.
Yeah.
I think Jordan did another piece around how normal beer is much better for you than no alcoholic beer. It has more goodness and other things in. So as long as you're having
happy days.
Yeah. But again, it's in the place. 10 pints of anything is not going to be good for you, really.
For sure.
So I think moderation is key. And, I know family members who I've diagnosed with reflux, and they've gone onto PPIs and they've gone, it's great, I can eat and drink whatever I want now. I'm drinking more and more, and I'm thinking, oh God. That wasn't
That's not the intention.
That wasn't the intention. I think it's an important part of our culture, important part of our enjoyment, and also an important part of our gut health. I think there is enough evidence now that things like red wine and a normal amount of beer is probably as part of
it's not a bad thing.
It's not a bad thing,
because the sort of the extreme end would say alcohol is a toxin. Absolutely no amount of alcohol is good for your body, full stop. And I guess I could make the case for that. The flip is, as you say, the blue zones, particularly in the Mediterranean places, Sicily, Sardinia, they're drinking every day. Small amount, very high polyphenol content, but really relative to a punnet of blueberries, probably not that high. The other aspect, though, I think, which is important, is if it's part of a social experience. I mean, having a half pint of whiskey yourself to put you to sleep, not sure that's so good. But a glass of red wine as part of a social experience that lowers stress levels. Maybe there's some aspect to digestion. I don't know. If you relax, you digest better. I don't know.
Increases blood flow to your stomach. Alcohol.
Right. Okay. So is there some truth to the digestive then?
Yeah.
It's a real.
Yeah.
So how does that work then? Because I hadn't.
Well, it's a kind of vasodilator, isn't it? So the alcohol goes in and you get an increased blood flow, and therefore you get better function and better absorption and everything. Then in the digestives, the Germans love their digestives, don't they? With all the herbals and things that go on. So there's some science to back up the post-dinner sambuca. Is it sambuca? What is it? They have a sort of... Oh, there's all sorts, isn't there? But I guess the most common one that all people know is something like Jägermeister, which has become like, bastardized by the Jaeger bomb.
The Jaeger bomb. Yeah, exactly.
But actually, if you look at it, it's got like 15 different botanicals in it, and it's basically a medicine with a bit of alcohol. If you think about a lot of old medicines, if you go, especially in Germany, I think, because my son lives out there, then the herbal remedies with alcohol. There's a place in North Germany where they've got a digestive called the Schlugger der Lamp. Basically, they had a lamp in the pub because it was banned. So when the police came in or whatever, then they wouldn't be able to find this. And then when they'd gone, they opened this fake lamp, and there was this stuff. Lamp. So when you go in there, it's kind of a rite of passage. You have to try it.
That's very
so. Yeah, there's definitely quite a lot of medicines had alcohol in them, didn't they? Going back in time, cough medicines and things. So
yeah.
If you go listen, I always listen to Sherlock Holmes audiobooks, and they're always putting a wee bit of brandy on your lips to cure everything from stabbings to
a cure-all.
Yeah,
it's good to know though that there's actually some science to having a bit of booze before or after or during.
Yeah, and I think it's like everything else. I mean, what you want in life is if you have a varied and interesting diet, then you'll have a varied and resilient microbiome.
Yeah. I completely agree with you. So maybe we can go back to IBS again. We'd got to the small bowel, now we're going to the colon, large bowel.
My favourite part of the body, the proximal colon.
Is it your favourite part?
Yeah.
Why is that?
It's just so much going on.
More than the small...
Oh, the rest of it's boring. Yeah, the rest of it's just getting stuff into the system. Yeah, but the proximal
immune
colon...
system activation, no? I mean, there's a lot of dendritic cells and stuff in the...
But if you imagine all of the stuff that you can't digest, then nature has given you this second stomach, and it's packed with trillions of microbes.
You're making the case already, yeah.
And it's got rich innovation, it's got rich blood supply. And, one of the studies we did with Smart Pill, which allowed us to look at the pH across different sections of the bowel, showed that the pH in the proximal colon is lower than in normal people. But the pH in the colon never drops below 5, because 5 is the point at which fermentation stops.
Oh, yeah.
And at that point, fermentation stops, the carbohydrates build up, you get this kind of osmotic drive into the colon, and that's what then causes the loose bowel motions. So we called this, instead of gastroparesis, it was secoparesis. And we didn't really get away with it, but instead of diarrhea, it was anal vomiting. Because it was the stomach basically saying,
see you later.
We can't hold on to this anymore. And it's not diarrhea, because diarrhea is watery and it's infectious or whatever. This is the proximal colon saying, all right,
we don't want it.
Yeah. And this is why people have the alternating bowel habit. So they feel bloated and constipated, and then it goes anal vomiting. Yeah. So I think that for me, if you look at the small bowel coming down, it's like the esophagus. You've got the ileocecal valve, which is like the lower esophageal sphincter. You've got the proximal colon, which is like the stomach. And then you've got the rest of the colon that then just transports the waste material out. So the proximal colon for me is both a therapeutic target, a symptomatic target, a diagnostic target. I think it's the most interesting area. And what we've recently discovered is that what happens in the proximal colon actually is responsible for a lot of people with throat symptoms. Because when you're...
What?
This is great. So studies that I'd not even seen from like the 1990s show that if you infuse short-chain fatty acids into the colon, into the proximal colon...
Through a colonoscopy?
Yeah.
Tube up the bum, tube up the bum, yeah.
Then the proximal stomach relaxes and you get more lower esophageal sphincter relaxations. So this is the body getting ready, because you're right in the middle, aren't you? So the gas is going to be either come out that way or come up that way. So everything is relaxing to accommodate this excessive fermentation. So when you burp normally, comes up, what do? You swallow. So all of the gases and digestive stuff that comes out with a belch is then neutralized by your saliva and you swallow down. But what happens if that occurs at night time when you're asleep? The valve opens, the gas comes up, and it's mixed with short-chain fatty acids and other digestive enzymes. The back of the throat relaxes because it's venting, because it's a belch, it wants to get rid of it, but you don't swallow, so it sits there for a long time. And we can actually measure this now with pH probes and other probes. So for years and years and years, going back on PPIs, people with throat symptoms, they thought it was reflux, they give you more and more PPIs, and it's been shown now through the TOPIC trial it doesn't work, and actually probably makes it worse, because that causes dysbiosis, which then creates this excessive fermentation, proximal colon distends, you get these nighttime reflux events, which are not acid related, they're digestive enzymes, and that's why you get the sore throat. Wow. So we're about to publish this.
Fascinating.
Yeah, it's understanding how the gut functions. That's what's important. The bidirectional nature of all of these nerve impulses talking to different parts of the gut, getting ready for things.
It's all connected.
Once you understand it, then you can treat it.
Yeah.
That's the challenge, and also, the prize, really.
Where do you see the future going for the proximal colon? In terms of the diagnostics, the therapeutics, how big could it be as a platform?
I want to turn this on its head a little bit and ask you the question.
Okay. Sure.
So, and this will lead into what I think is the future. So, the microbiome in the proximal colon is different from the distal colon, and what you map when you're taking stool samples. So, how do you reconcile that when you're kind of trying to design therapies? But because the proximal colon microbiome is much more similar to the small bowel microbiome than it is to the distal colon. But so how do you reconcile that from your kind of understanding of it?
Well, I think stool, although it is different to the various different aspects in terms of anatomy within the digestive tract, when you look at the microbiome composition and function, it is the sum of all of the microbiomes in the digestive tract. So it does represent what's going on elsewhere. It's never going to be as good as getting a sample from the exact part. But what I would say is, because of things like the migrating motor complex, peristalsis, all these things, what you put into some part of the upper GI tract is probably going to find its way to a site somehow. The mechanisms are unknown. It's very difficult to study that, because of the same reason that it's difficult to, at each different anatomy, study the microbiome, particularly if it's inside your body. Not figured that out yet. So our approach has been, you want a very high diversity product with a lot of functional redundancy. The reason for that is that many of these conditions is probably going to be something going wrong at various different parts of the GI tract, We can't precisely modulate them at this particular point in time. And the microbiome of every single patient is different, right? So we've always struggled with, well, we're going to select 6 strains or 12 strains that we've identified as being potentially associated with efficacy in an FMT study of 20, 30, 40, 50 patients.
Mm-hmm.
And we've struggled with that because it's just one small segment of the population. It's one clinical study from one FMT. And if you ran the same experiment in 20 different parts of the world with 20 different FMTs, are you going to get the same 6 strains? Is it really those 6 strains, or is it just those 6 strains in that study? So we've approached it fundamentally differently, which is that if you've got a high enough diversity, you've got enough shots on goal to deliver the functional reinstatement that you need in these patients. And we believe that's the best you can do today. As things progress, the way we see things working with our company is that when the drug goes from phase 1B to phase 2 and phase 2 to phase 3, we will deeply analyze the microbiomes of the patients and the rest of the body and try to infer trends. And we'll maintain the full spectrum platform because of the functional redundancy being a core product strength, but make sure that in every single product, we've got these groups, which we've identified based on our studies as potentially being therapeutically important based on their function. So that's how we see our products progressing. Now, in the future, goodness knows when this is going to be, but I could conceivably see an approach where with targeted microbiome delivery, be it a precision approach with a phage or a small group of strains that are known to, in all people, have a positive impact on this function in the small intestine, you could do a much more targeted precision therapy. So in a very kind of long-winded way, we believe you start with the full ecosystem. There's also aspects of the ecosystem beyond the strains of bacteria that might be important. It's very complex.
Very complex.
It's super complex. I mean, maybe it is the most complicated thing in the known universe.
Yes.
So when companies say, well, it's this one strain or these 12 strains, I think I'm really skeptical about that.
You throw in the nervous system, the immune system, your genetics, the environment, and then all the strains and all of that. It's unfathomable.
Yeah. And people will say FMT is not safe, and there's people in the IBS community who are pretty strong against FMT because they believe that to treat IBS you need to give antidepressants. Okay, because I think, and I'm not trying to downplay or discredit anyone or attack anybody, but I think that school of thought suggests that it's more of a brain gut thing. It's more of a nervous system thing than it is a microbiome gut health thing. And for some patients, I think that's probably correct. But for others, something's gone wrong in the microbiome, which is maybe making them irritable.
As we touched on,
yeah. And some people say, well, FMT is not safe. I say, well, is that really true? Is it really not safe? Think about it objectively. The first FMT in modern medicine was done in 1958 by Mr. Ben Eisman in the Denver General Hospital for C. diff. Since then, there must have been hundreds and hundreds of thousands of procedures. And I know that because one stool bank alone in America has done 100,000. So it's maybe even an order of magnitude more.
Yeah.
Someone should map that out. Maybe it's one for a PhD student somewhere. How many deaths have there been? A handful. 2 very high profile ones in the New England Journal of Medicine, and then there's some others that have been potentially associated. So actually in reality, it seems to be quite safe from a death perspective. The bigger unknown question is, well, does it drive some other phenotype?
Yeah.
You'll have seen the Netflix documentary.
I think the South Park episode's better.
South Park episode's better, yeah. So, I've got acne because I had an FMT. Well, maybe that's true, but also maybe it's not. So I'm not giving you my version of the future. I think the future is full spectrum for a long time. That we might become donor independent as the next step.
Yeah.
But I feel like we're a very long way away from this vision of, well, for every single manifestation of a gut health problem, we're going to be able to give you a cocktail of bacteria. And I think the clinicians who are pushing that are doing the wrong thing right now. I think it's fine to say in 100 years we might be able to do that, but let's not talk that up as being, a viable approach today, because it's just, frankly, it's just not. There was a Nature briefing article published, I think, last month that said, basically FMT works in some patients, and it works incredibly well. These are cancer patients who are taking an immunotherapy, and there was a publication last week, staggering results, where if you give this up front with an immunotherapy, you're getting a much, much better result. Why? Well, think about all those dendritic cells and everything like that. Yeah. It says they wouldn't be widely used, partly because of access, but also because we need defined cocktails. And it's like, what is this obsession with defined cocktails? Why has it arrived, and why do we not just obsess with making FMT as safe as possible because it works?
Yeah. Which
gets us onto enterobiotics. However, it's not an enterobiotics podcast. It's a Professor Anthony Hobson podcast. So,
well, fortunately, I'm working in parallel with you guys, because the reason I wanted to ask the question was, stool is basically the waste product at the end of the metabolic process. And the bit of research that I'm really excited about is our collaboration with Alstone Medical, where we've not only looked at stool samples, but we've also looked at volatile organic compounds on breath.
Yeah.
So what happens in that engine of metabolism in the proximal colon? So you've got carbohydrates and proteins and chemicals and interacting with all these microbes, and all these products are being short chain fatty acids and all sorts of other products are being done. But how can you measure that? So we did a study, we've done it in nearly 50 healthy volunteers as part of an iron supplementation study, and we've used Alstone's technology to basically capture all of the volatile compounds at baseline. So these are your kind of endogenous volatile compounds that your body produces. And then we've given a lactulose probe, and at different time points, we've stimulated the microbiome by that basically breaking down the lactulose. Then all of those compounds that are being absorbed into the bloodstream come out on your breath. And over 600 different compounds can be measured on these tubes. So, we started like needle in the haystack type thing of looking at things like short chain fatty acids. So can you look at butyric acid? Can you look at propanoic acid? Well, guess what? You can. So what we're able to now do is then look at the diversity of the compounds in the same way you look at the diversity of the microbiome. So you can run Shannon and Simpson index and you get similar kind of diversity measures. So if you get a diverse volatile organic compound profile, then that's probably quite healthy.
Yeah.
But if you've got big spikes in things that may be more pathogenic associated with inflammatory processes, then what we're hoping is that it'll be a surrogate marker. So instead of looking at the end product, you're looking at what's happening during that activation phase of the microbiome. And what we're hoping is you'll find a kind of therapeutic window for short chain fatty acids, where if you have too few, you need to increase the butyrate producing compounds, or if you have too much, like we saw with the IBS patients, where you produce too many short chain fatty acids, that's either due to something like carbohydrate malabsorption or dysbiosis, where they're producing too much. And from the IBD literature, there is this kind of protective window that you want to bring people into. So what we're hoping is that this will be developed as a completely non-invasive test of microbial metabolism. I think that in conjunction with the it will be a big step forward for us.
I mean, within the field, and I'm speaking extremely broadly now into areas that I'm not an expert, but there is an appreciation across the board around stool being a proxy for the gut, but not necessarily being optimal for lots of different reasons. It is indeed some product of all of your waste. And one of the biggest limitations, I think, is that the large bowel microbiome is very different to the small bowel because of the acid and its function and so on. And for many of the things, we're possibly talking about small bowel proximal colon dysfunction rather than a large bowel dysfunction.
Absolutely.
At all.
Yeah.
And we mentioned SIBO at one point, I think, as well. Might be worthwhile just unpacking that, because there's a lot of myths and misconceptions about SIBO, small intestinal bacterial overgrowth. And some people are skeptical about it even being real.
It's just totally insane. It's like, you know, it's such an easy concept, isn't it? That people who've got SIBO, every time they eat, they feel like they've been poisoned, and that they're told it doesn't exist. So why do they feel like that? So your small bowel is small and sensitive.
Yeah.
And if you start digesting, you know, proteins and putrefying proteins and things in the small bowel, and digesting carbohydrates and producing short chain fatty acids that stimulate the vagus nerve and everything else in the small bowel, it's going to be pretty pissed off. And therefore, we've got a test that you can use, and whether it's distal small bowel or whether it's proximal colon or both contributing to the dysbiotic profile, what we know is that if you have a positive breath test, you get a much better response with rifaximin, like up to 40% better than if you have a negative breath test. Now in medicine, that's pretty good.
It's excellent.
So you have a biomarker that's specific to the microbiome, i.e. hydrogen and methane production. You've got a substrate that is only digested by those microbes, and it correlates with treatment. And even if it's not a perfect test, it's still better than treating people empirically with antibiotics, which is the guidelines in the UK at the moment.
Yeah. Is that right?
Why would you do that? Oh, we think it's bacterial overgrowth, give them some empirical antibiotics. Or, you know, you talked about tricyclics before. I'm sat in an MDT, someone says they've got TDS. What's that? Tricyclic deficiency syndrome. Yeah. There are people who just want people to forget that their gut is causing them these problems. Wow. But if you think about some of the downstream effects of what bacterial overgrowth can cause, whether it's malnutrition or just quality of life and everything else, I don't understand why it's so politically, you know, a problem between gastroenterologists. But actually, we're moving on from that now. You know, it's a moot point for me. There are treatments and non-pharmacological treatments now for SIBO that, you know, we're going to, you know, trial and pursue and just help those patients, and hopefully gastroenterologists who care about their patients will come with us on that journey. And
is it IBS? Is it fair to say it's IBS or a form of IBS, or is it something distinct?
I think it's higher prevalence in patients with IBS symptoms is the key. But of course, you still got that dogma of IBS being characterized as a lifelong condition. And I think, again, Mark Pimentel's probably been front and center of this, of saying, you know, towards a cure. Because if it is due to SIBO, you can get rid of SIBO. Yeah. People get better. Everyone's been on holiday and got the squirts. And then for about 2-3 weeks afterwards, I can feel my migrating motor complexes. Yeah. I have to get up in the night and eat some bread to switch them off, because my nerves are sensitized, and then it goes back to normal. So, but for some people, it won't go back to normal, and then, you know, they'll develop IBS for it. So, but for some people, you treat the SIBO, and then they never complain about their gut again. So it's unraveling these myths around lifelong conditions. There are going to be people that can't absorb fructose, for example, as well as other people. So those people will have to modify that. But it's not the end of the world, is it? It's not a disease state. There are people that, you know, maybe have intractable anxiety and you know, depression that will make them more aware of sensations. But it's unwrapping the phenotypes really and finding out, and not giving everyone the label, you've got IBS, go and live with it, because then they've got it for the next 50 years and they'll have food avoidance behaviors and everything else. So
so if we're talking about the future, you know, sounding like we're hoping for a world where that umbrella diagnosis for IBS almost disappears or becomes something different. It becomes, you know, you have excess methane production. The reason for that is because you have methane producing archaea in your gut. And what we're going to do about that is we're going to either get rid of them, or we're going to suppress them through diet, or we're going to outcompete them through something like IMT.
Yeah.
That's kind of where we're going. Whereas at the moment, it's you're bloated, try low FODMAP, goodbye.
Yeah. Which laxatives or, you know, other things that have deleterious effects.
I mean, low FODMAP is effective, and it makes sense, right? It's low fermentation eating, essentially. But when you speak to someone who's actually done it properly, it's extremely restrictive. Well, you can't really go out for dinner with friends and go, right,
it's not curing it, is it? You're starving the bacteria.
You're starving your microbiome.
But then what comes back in its place? You know, that's a good question. And that's one of the problems that you have, is when you start to reintroduce, then the bacteria that maybe harvest more energy from those carbohydrates and produce more hydrogen and more short chain fatty acid, they could actually have a rebound effect.
Yeah.
And that's where I think a lot of dietitians got a little bit spooked by some of the data around, microbiome after low FODMAP. And so if every time I eat I was nauseous, if I don't eat, I've cured my nausea. Yeah. but I won't thrive.
But you need to eat to be healthy and happy.
So it's and what they're trying to do now, obviously with the 30 different seeds and fibers and whatever, and I think that's all very admirable, and the Mediterranean diet and making it more tolerable. And there are things that you can take along that journey to make things more tolerable. So my wife doesn't tolerate onions and garlic very well, but if we're going for like an Italian, she'll take some digestive enzymes and maybe a bit of enterous gel before bed. Yeah, and that just keeps the symptoms at bay, and she gets the benefit of those nutrients without getting some of the symptoms. Protecting before you go away on holiday and things, and priming your bowel with new dietary changes. There are all sorts of different things hacks that you can do to sort of prevent that without being restricted. But my big fear is that a lot of the wellness devices that are around, whether they're longitudinal measuring fermentation gases or things that are looking at blood glucose, put too much attention on food choices, and food avoidance behavior is already very prevalent in people with IBS type symptoms, and I worry that you'll drive them towards an eating disorder and make longer term effects, rather than making food more of a friend and
absolutely
seeing how that they can moderate their diet and still have a diverse diet without getting too many symptoms.
Now, you're a big fan of the intestinal absorbents.
Adsorbents.
Adsorbents, not ab.
So ad means that things stick to it rather than get sucked into it. Absorbents is these have been around for quite a long time. They were designed. People have used charcoal and certain clays for many years, but these silicon-based adsorbents have been around since Chernobyl. They were designed after.
Really?
To look at the after effects of radiation sickness. But essentially, they're a bit like, again, putting a kind of dishwasher capsule on a rinse cycle. So if you take it at night, then the gel, you mix it with water, drink it. It just basically soaks up some of the toxins, the bacterial toxins, and other large molecules that cause irritation, and settle things down. And the guys at Intestinal did a really amazing study in IBSD a couple of years ago, randomized control, placebo controlled, a couple of hundred patients, many sites, and showed really good efficacy in IBSD. It also works in acute diarrhea, so it reduces the time if you get diarrhea, which is great for people like sports people who want to get back on the pitch and things. So for me, putting it in the arsenal of protection and treatments is a no-brainer. It's on the NHS formulary now, although it's not always easy to get people to prescribe it. Yeah. But I think it's a really innovative and easy to take and safe medication that I think, particularly in that acute phase where you want to get control of symptoms, and then further down the line in that protection phase where if you are
an athlete, for example,
athlete, but also if you've previously had SIBO, then you tend to be a bit more prone to getting foodborne infections again. So if you go into a destination where you might get more chance of having it, then just take it as a preventative as well. Nothing spoils your holiday more than being on the toilet for 3 days, does it?
We've all been there, right?
Yeah, sadly. It's
worth taking some. So just because we're running out of time, we've been talking about all sorts of things. Maybe we can finish by you telling the listeners what your vision is for the Functional Gut Clinic over the next few years, and kind of what you're most excited about for the field.
I think the exciting thing for us at Functional Gut is that we've finally closed the gap across the whole digestive health continuum, from better version of yourself through to tertiary. So we now have solutions and information and tests for people all along their digestive health journey. So a lot of that's prevention, education. Never want to see you just want to read our thing on our website, through to testing new products, not over medicalizing digestive health things, so you don't have to go to the GP. We've ruled out the red flags. You can just do this yourself, but then having entry points for people to escalate up if they need it. And I don't think that's ever existed before. There's not been a joined up pathway. So we've got patients in flare. We want to put them into repair. We want to keep them in remission. We want them to have a long and healthy life without having to take tablets that allow you to have half a pint of whiskey a night. So That's the exciting thing for us is this digestive health continuum.
Yep.
We've now got strategies across it, whether it's free to access information through to tertiary tests for people who need it.
Yep.
And I don't think that joined up solution has existed before.
Thank you for that. And if people want to follow, we talked about TummyMOT, functional gut, follow you, how do they do that?
So TummyMOT.com is our free to access resource where we review products and give digestive health tips. And Functional Gut Clinic, thefunctionalgutclinic.com is our clinical site for people who may be interested in taking tests.
Awesome. Thanks so much. Really enjoyed that. I'm sure the listeners did too.
Thanks for inviting me.
Thank you.
Cheers.